This is one of the very basic concepts of the respiratory system. We breathe in oxygen and we breathe out carbon dioxide. There are a couple of lower respiratory structures that we're going to talk about. The first being the bronchi, which is the main path into the lungs. The second is the bronchioles, which are the lung structures that are surrounded by smooth muscle that can constrict and dilate. So this is where we get the terms bronchoconstriction and bronchodilation. Next are the alveolar ducts, and this is the area where the alveoli are located. Last, we have the alveoli, which is where gas exchange takes place. If smooth muscle contracts around the bronchioles, bronchoconstriction is happening. If smooth muscle relaxes around the bronchioles, bronchodilation is happening. To answer these questions, you need to know what pulmonary edema is. Pulmonary edema is fluid inside of the lungs. If we have fluid inside of the lungs, we will have fluid inside of the alveoli. If fluid builds up inside of the alveoli, we affect gas exchange. In this case, gas exchange will be decreased. This will also affect oxygenation because if the alveoli are filled with fluid, gas exchange can't happen as well, so your patient won't be able to oxygenate as well. To answer these questions, you need to remember what atelectasis is. With atelectasis, we will see collapsed alveoli. Next, we need to know if gas exchange occurs when this happens. If we have collapsed alveoli, the alveoli cannot participate in gas exchange, which means gas exchange is decreased and the patient is not oxygenating as well. So why is a post-op patient at risk for atelectasis? For a pharmacology reason, we're going to think about the anesthesia that this patient has had. For our mobility reason, we are thinking that since our patient had surgery, that they're probably not moving around or ambulating as much as they typically would. For our comfort reason, we are thinking that this patient might be in pain. So we really want to educate this patient to stay on top of their pain control so that they can get up and move around. Also, if your patient is in pain, they may not be taking deep breaths, which could lead to atelectasis. What all of these things have in common is that they all decrease the amount of deep breaths your patient is taking. The anesthesia may hinder their respiratory drive. With mobility, they're not up around moving, expanding their lungs. And for comfort, if they're in pain, they may not be taking deep breaths. There are some things that you can teach your patient as the nurse that would help promote gas exchange. Some of these things would be turn, cough, deep breathe, incentive spirometry, early mobility, and pain control. This slide is just a reminder that you have 3 lung lobes on the right side and 2 lung lobes on the left side. This slide is a review of how oxygenation happens. We need to remember how blood travels through the heart. So first, the right ventricle sends unoxygenated blood to the lungs through the pulmonary artery. Next, the oxygen and carbon dioxide exchange happens in the lungs inside of the alveoli. The now oxygenated blood travels through the pulmonary vein into the left atrium. The left atrium sends blood to the left ventricle. The left ventricle sends oxygenated blood to the entire body, which is our cardiac output. If you look at the picture on this slide, it'll really help you make sense of these chest wall terms. First, we have the parietal pleura, which is the membrane that lines the chest cavity. So this is the membrane that is closest to the chest wall. Next, we have the visceral pleura. This is the membrane that lines the lungs. So when we think about the word visceral, we think about organs. And the lungs are an organ, so this is the membrane that lines the lungs. We also have the intrapleural space, which is the space between these 2 membranes. The intrapleural space contains a tiny amount of fluid, only about 20 to 25 milliliters of fluid. The purpose of this fluid is to act as a lubricant so the 2 membranes can easily slide over each other as the patient breathes in and breathes out. If we have more than 25 milliliters of fluid in that intrapleural space, it is considered a pleural effusion. If the fluid in that space is purulent, we would call it empyema, and that is an indication of an infection. What are two common causes of pleural effusions? The picture on the slide is your hint. We have a cardiac reason and a renal reason. The cardiac reason will be congestive heart failure. The renal reason will be chronic kidney disease. What these two disease processes have in common is an excess fluid volume. The second question on the slide is, purulent fluid in the pleural space can indicate what? And the answer here is infection. The diaphragm is our major muscle of respiration. If you look at the pictures on this slide, you can see that the diaphragm sits horizontal right underneath the lungs. What does the diaphragm do during inspiration? The diaphragm moves downward to make more room in the thoracic cavity so the lungs can expand. Why does the diaphragm do this? It does this so the lungs can expand to fill with air. When we exhale, the diaphragm will push back up on the lungs to help expel that air outward. As the thoracic cavity gets bigger, the pressure inside that area decreases. So think about this. You will always have some air left inside of your lungs. So if you think about that air in a smaller space versus that air in a now larger thoracic cavity, we know that with the same amount of air in a larger area, that the pressure would be lower. You also need to know that gas flows from high pressure to low pressure. Since gas flows from high pressure to low pressure, when the pressure inside the thoracic cavity decreases or becomes lower than the air pressure of the outside environment, air is pulled into the lungs. So as your patient is starting to take that breath in, they are trying to equalize the pressure. So they are trying to take the high pressure from the environment and equalize that by pulling it into the low pressure inside of their lungs. Your patient will continue to inhale until the pressure inside of their lungs becomes higher than the pressure of the outside environment. When the pressure inside the lungs becomes higher than the outside environment, your patient will get a signal from their brain to begin exhaling. Again, this is constantly trying to equalize pressure. So, a decrease in intrathoracic pressure results in pulling air into the lungs. This breathing process is controlled by a nerve that lives between C3 and C5. So any complete spinal cord injury above the level of C3 will result in total diaphragm paralysis. And this will result in the patient being dependent on a ventilator because they are no longer getting those signals to breathe in and breathe out. If we decrease intrathoracic pressure, we pull air in. If we increase intrathoracic pressure, we push air out. Two terms to be familiar with are ventilation versus oxygenation. They are not the same thing. Ventilation is the process of air moving in and out. This is your patient breathing. So inspiration and expiration are inhalation and exhalation. Oxygenation is your patient breathing in that oxygen and actually getting that oxygen to their body organs and tissues. So is it possible that your patient can be ventilating but not oxygenating? Yes. Your patient can be going through the motion of breathing in and out, but it doesn't necessarily mean that they are getting oxygen to their organs and tissues. Some assessment findings of a patient who may not be oxygenating well include restlessness, irritability, confusion, increased respiratory rate, shortness of breath, dyspnea on exertion, accessory muscle use, increased heart rate, cyanosis, cool, clammy skin, diaphoresis, and fatigue. Dyspnea is just a review of a vocabulary term for you. This means shortness of breath. When you think about elastic recoil, I want you to think about rubber bands. What this is the lungs returning to their original size after expanding. So just like a rubber band returns to its original size after you stretch it out. This is a passive process, so this happens all on its own. The question is, do you think it is triggered by an increase or a decrease in intrathoracic pressure? This is triggered by an increase in pressure because remember, gas moves from high pressure to low pressure. So once the pressure inside of the lungs are increased, that is when you will start receiving those signals to start exhaling. And to exhale, the lungs need to return to their original size. Compliance is a new term, and this is just how easily the lungs are able to expand. An increased compliance means that it is easier for the lungs to inflate. A decreased compliance means that it is harder for the lungs to inflate. There are some respiratory problems that would result in a decreased compliance, so let's talk about them. First on the list is respiratory problems that involve having increased fluid inside of the lung. This makes sense because we know if your lungs now have fluid inside of them, that fluid will provide extra pressure, which will make it harder for the lungs to inflate. Next, we have diseases that make the lung tissue less elastic, like pulmonary fibrosis. When we think about pulmonary fibrosis, we think about hardening of that lung tissue, and that makes sense that the lungs would have a harder time inflating if the lung tissues were hardened. Lastly, we have anything that restricts lung movement. So maybe we have an increased amount of fluid around the lungs, like with a pleural effusion. If we have that pressure of the fluid on the outside of the lungs pushing down on the lungs, it makes sense that it would be harder for the lungs to expand. Resistance is anything that blocks airflow in and out. So air meeting resistance won't be able to move as easily as if it wasn't meeting resistance. An example of this would be a narrow airway with an asthma exacerbation. We know it's easier for air to flow through a nice wide bronchiole rather than a constricted bronchiole like we see with asthma. This can also be caused from secretions partially occluding the airway and causing a narrowing of the airway. So, can bronchodilators help with this? Yes. Bronchodilators decrease resistance by making the bronchi wider. Why does this help? Because air can flow in and out more easily through a wider bronchiole. Can changes in compliance and/or resistance affect oxygenation and ventilation? Yes. Why is this? Because compliance is how easily the lungs can expand, and resistance is how easily air can move. Chemoreceptors are receptors that respond to chemical changes. One of these chemicals is hydrogen. Hydrogen is acidic and plays an important role in breathing. Chemoreceptors in the medulla send impulses to the respiratory muscles. These impulses first travel through the spinal cord and phrenic nerve to control respiration, which is why sometimes we will see changes in breathing or breathing paralysis with spinal cord injuries. Can the lungs help fix acid-base imbalances? Yes. How can the lungs correct acid-base imbalances? The lungs can breathe off carbon dioxide, which is an acid. If there is an increase in hydrogen concentration, which is an acid, the medulla will send a signal to increase the respiratory rate so the body can breathe off the acid faster. If there is a decrease in hydrogen concentration, which again is an acid, the medulla will send a signal to decrease the respiratory rate so the body can hold on to that acid and doesn't breathe out that acid as fast. In a healthy person, a decrease in pH, so remember that's a lower number, will cause an immediate increase in the respiratory rate to fix the acid-base imbalance. We will cover the rest of this in part 2.